Hello, everyone. Welcome to the Duke Spine Surgery stream here for December 7th. Dr. Duke is getting ready for his surgery. Meanwhile, you guys can type out questions up in the chat for Dr. Duke to answer live. Meanwhile, we will have our ads running and our testimonials. Thank you, and please be patient.
Dr. Ara Deukmedjian here today with you from Duke Spine Institute on our YouTube channel with Spine Scams Exposed. And we're going to talk in this segment about artificial discs. All the hype, all the buzz, are they really that great? Are they the answer to all the problems that people are having with pain in their neck or back? What are the advantages, pros, of having an artificial disc, and what are the cons? Is the artificial disc really the best treatment for you? These are all important questions that people ask, and we're going to have some answers for you today. So first of all, what's the purpose of doing an artificial disc surgery? Well, it turns out that in some people, they develop a damage to the joint called the disc in their spine. And we have discs in our neck, we have discs in our lower back. The discs are the big joints that allow movement between the bones. Fact is, discs do get injured and they do cause pain. So you can actually go in there and remove a disc, and instead of fusing the two bones together that are on the top and bottom of the disc, you can put a metal disc in there that moves around. So metal discs have sort of taken the place of fusion in many places. Is that really the best option? In my experience, no. I've looked at the data from all the studies that have been done on artificial discs, and I believe that the fusion data is actually better than artificial disc data. The complication rate with artificial disc surgery is said to be the same as fusion. It's around 5% to 10%, depending on the study you look at. So let's just take a look at one of these patients who had artificial discs put in their neck. And remember, artificial discs were first approved to do one disc, and then they expanded to two, and now three, and there's really no limit now. Artificial discs are put into multiple disc herniations and disc injuries, and people are getting them put in all over the world. So are there any issues with these artificial discs? The answer is yes. Let's take a look at this MRI right here. This is a cervical spine MRI, someone's neck, and if you look at my arrow and follow it down, you can actually see that this person had two artificial discs put in through the front. They had them put in at, if we count 2, 3, 4, C5, C6, and C6-7. And you can already see the artificial discs are getting pushed out of the disc space. They're actually popping out of where they were put during surgery. Okay. Here's an example of those discs, and you can see they've migrated. We call it migration, where the disc has actually moved out of where the surgeon put it. You can see the one at the bottom has moved off to the side, and the one above it seems to have popped out in the middle. Okay, that's a spine x-ray. If we look at the side view, you can see it better. You can actually see that there's two disc herniations, two discs that were herniated and repaired with these cages and artificial discs. All right, so these things can pop out, and they can cause lots of problems for people, and you need to be aware of it because they're not a perfect solution. There's still a piece of metal that's being put in your spine, and there are forces on the spine that occur when you flex and extend, when you laterally bend, and when you rotate. And when you start to move your head in multiple directions at the same time, you're putting a lot of different forces on that artificial disc, and it can literally just pop out of place. So migration of artificial discs is one of the biggest problems. It happens, and when it happens, it's bad. The surgeon has to go in there emergency surgery and get through all that scar tissue from the last surgery. It's very dangerous. You could have blood vessels stuck together and stuck to your esophagus or trachea, and they have to rip those open and cause horrible complications like strokes and paralysis. You want to avoid it. Far better than an artificial disc, I recommend you take a look at the Deuk laser disc repair. With the Deuk laser disc repair, there is no artificial disc, there's no fusion. We don't put any metal into your spine. It's literally endoscopic repairing the back of your disc where the problem is. We leave your natural disc. So there is no total disc replacement, there's total disc leaving. And basically you get to keep your disc that you had, that you were born with, that's still working fine. It's just the part in the back that needs to be repaired, and that's what we do with the Deuk laser disc repair. All of this is done with a very precise medical grade laser called a Holmium YAG laser, and the procedure is done outpatient. It's not even done in the hospital. You do it in a safe clinic at Deuk Spine Institute. Hope you enjoyed this segment and learned a little bit. I'm Dr. Deukmedjian with Spine Scams Exposed. This is Dr. Ara Deukmedjian, the surgeon who will be performing today's live surgery that we're streaming around the world live. And our stream is supported by Deuk Spine Institute, Surgery Center of Viera, and the Deuk Spine Foundation for Research and Education in Spine. Today we have two surgeries. The first one that we'll be broadcasting this morning is a problem with the cervical spine, which is the part of the spine found in the neck. And problems with the cervical spine account for neck pain, headaches, and symptoms radiating from the neck down the shoulders and into the arms. The symptoms that radiate into the arms could be on the right side or the left side or even both sides. Now, what causes the symptoms to go into the arms? That is the effect of a disc herniation on the nerve roots. That nerve roots are basically how the brain talks to the fingers, the hands, and those areas talk back to the brain. The signals travel through basically a organic fiber that sends electrical signals that travel along the nerves. And the nerves go from basically the spinal cord, where their cell bodies are, over to the ends of the fingertips. There's two types of nerves. There are what are called motor nerves and there are sensory nerves. Motor nerves are responsible for movement and the muscles. They control the muscles that cause movement of your hands, your fingers, your arms. And the sensory nerves, on the other hand, are responsible for feeling. So whatever you feel, cold, hot, pain, pleasure, touch, all those sensations that go through your skin and even the position of your joints are transmitted along a second type of nerve fiber called the sensory nerves. Now, the motor nerves and sensory nerves are bundled together in what's called the nerve root and then the peripheral nerve, which is further down the arm. So a herniated disc or bulging disc, any problem with the disc that causes inflammation will affect the nerve roots, and compression of the nerve roots can also affect the nerve roots. So there's two types of processes related to the herniated disc that will affect the nerve roots. The first is inflammation, which is irritation of the nerve roots, which can cause weakness, numbness, tingling, and pain down the arm. The other thing that happens is compression of the nerve roots from a herniated disc, usually on spinal stenosis, which causes squeezing of the nerve root itself, which can also cause weakness and numbness, but less commonly pain. The pain that people get down their arm, I've discovered, comes from inflammation of the nerve root covering or dura around the nerve root in an inflammatory process. The weakness and numbness come from compression of the nerve root primarily. This is something that we discovered here, that I discovered at Deuk Spine Institute. This has not been published. This has not been discovered by the rest of the world. The rest of the world is lagging far behind Deuk Spine Institute, basically, in our understanding of the spine with respect to disc issues specifically, and the effect of disc herniations and disc bulges and compression on nerve roots. Unfortunately, there are some wrong ideas and misunderstandings that have been perpetuated for years. And the primary one is that neck pain and neck pain is unknown, the cause. Arm pain and weakness, numbness, and tingling are all caused by squeezing of the nerve root, like squashing it from a herniated disc or bone spur, a process called spinal stenosis or narrowing. However, it's not true 95% of arm pain, pain shooting from the neck down the arm, is actually caused by inflammation and not compression. And the inflammation doesn't come from spinal stenosis, it comes from the herniated disc and the annular tear that's irritating the covering of the nerve root. So for clarification, pain down the arm usually comes from inflammation in the back of the disc within the annular tear that affects the nerve root and causes pain down the arm. On the other hand, weakness and numbness usually come from compression of the nerve root, but can also be caused by inflammation of the nerve root. And so that requires a decompressive procedure, obviously, to unpinch the nerve root. And that is truly treating spinal stenosis, which is the narrowing of the holes for the spinal cord or nerve root. Now, another thing that can happen in the cervical spine or neck is a herniated disc or bone spur can actually press on the spinal cord itself, which could lead to paralysis. And that's something you really want to avoid, because once you're paralyzed, it's permanent. So the surgery we're going to be performing today, the Deuk laser disc repair, is being done on a patient who's already had a spinal fusion. I did not do their spinal fusion. It was done by someone else. And they're here now because they're losing function in their right arm and developing symptoms in the left arm. Specifically, they're losing strength and coordination in their right arm. It is coming from herniated discs above the prior fusion. And since the right arm is the primary arm affected, with the nerve roots on the right side being affected, specifically the C5 and C4 nerve roots, I'm going to be approaching these discs from the opposite side endoscopically, and I'm going to repair the disc rather than do additional discectomy and fusion. So one option for this patient would be to have a surgery called an anterior cervical discectomy and fusion. It's an open surgery. I've performed over 1,000 of these surgeries over the years that I've been practicing as a neurosurgeon. However, this patient wants minimally invasive surgery. He does not want another fusion. So he came to me because I perform minimally invasive endoscopic surgery without fusions, without artificial discs. There's no need to put anything foreign or metal in your body. You can do this naturally. Herniated disc, spinal stenosis, bulging disc, degenerated disc, all can be treated endoscopically now. We have the technology and the ability to do so. And by doing surgery endoscopically, we can avoid fusion, avoid artificial discs, metal plates, etc. Now, the surgery we'll be doing will be from the left side, and I will be making a small incision. The incision is literally 4 millimeters. 4 millimeters. Think about how small that is. It's literally, if you cut yourself accidentally, almost like a paper cut, that's how small the incision will be. And we're going to show you the incision today during the surgery, if you stick around. How's my audio feed? Not crackly? So we're going to get started soon. Our patient is now in the operating room. He is intubated. For cervical Deuk laser disc repair, patients need to be asleep. And the primary reason is we need the neck muscles totally relaxed. Relaxed means that if I touch the neck, the muscles won't tighten up. If the patient is awake, and you push on their neck, their muscles will tighten up and push your hand away. So it's like a reflex. We need to prevent that reflex from happening, and to do that, the patient must have what's called neuromuscular blockade, which means that we put a chemical in their vein that stops muscles from contracting. Now, obviously, breathing requires skeletal muscles to contract. So you breathe by making your muscles contract. Specifically, your diaphragm, which is a skeletal muscle, contracts and pulls down and opens the lungs and sucks air in. Also, your rib cage expands from contracting the skeletal muscles and sucks air in. So there are two mechanisms by which air moves into your lungs. One is the diaphragm contracting, and the second is the rib cage. There are some also ancillary muscles like your shoulder muscles that pull up on the rib cage. Point is, you require skeletal muscles to work in order to breathe. So when we chemically paralyze our patient's skeletal muscles during the surgery so that I can perform the anterior approach, these patients would not breathe. They would not do well, let's just say. So because of that, we have to intubate the patients, put them on a ventilator during the surgery. So we call that general endotracheal anesthesia. The Deuk laser disc repair, when it's done with general endotracheal anesthesia, we do it for the cervical spine only. For lumbar spine and thoracic spine, we do not do general anesthesia. We do propofol sedation with the patient awake, breathing on their own with maybe a little bit of assistance at times. So today's surgery will be done with our patient fully sterilely prepped and draped in the operating room. The patient will be completely asleep under general endotracheal anesthesia so that I can have complete relaxation of the skeletal muscles so I can access the spine through the front of the neck. Now, the initial access will be a procedure called percutaneous, meaning I'm doing it with a needle. So I'm going to use APN lateral fluoroscopy to guide the needle placement. We call that radiographic guidance and navigation. So I'm navigating to the part of the neck, the part of the spine that I need to get to using an X-ray machine to guide me. Why do we need an X-ray machine? Well, we're operating on the spine. The spine is made up of bones and joints between the bones. They're called discs. So in order to get to the right disc to fix it, because there are multiple discs in the neck, I need an X-ray machine to help guide me. So we'll be using an X-ray machine, and you'll see those pictures come through your screen once we get started. I'm going to say the word shot. That's a word that I used. It means take a shot, take a picture, basically. And that shot word means take a picture with the X-ray machine, and that's what you're going to see. Diego will flip over from the feed in the operating room to the X-ray feed, and you'll see that I'm advancing surgical instruments to the spine in a minimally invasive fashion with a tiny little incision. Now, are they seeing the surgery comparisons? So if you're watching the screen right now, what you can see on the left side of the screen is a fusion surgery. That's a metal plate and cages with screws bolting the plate to the spine. That is not what we're doing today. We're doing the Deuk laser disc repair, which was what was showing on the right side animation on the screen, or basically center panel. And you can see how small that incision is. And that right there is a little tube going into the neck with a 4 millimeter. I'm showing you the endoscope right there. The endoscope is a skinny long metal tube that has fiber optics, and at the end I can see whatever's at the end of that tube at the bottom of the tubular retractor that's going in right now. There's also a light source, there's irrigation, and there's a laser fiber, which you can barely make out as a blue fiber. Right now you can see not live footage, but recorded footage from a prior surgery where the laser is actually removing the herniation at the back of the disc. So I want to give credit where credit's due. The Deuk laser disc repair is pioneered by myself, and it's unique. It's very special surgery. It's different than all other surgeries in the world in that I was the first person to discover where the source of neck pain and back pain and thoracic pain come from when it comes from a herniated disc or a bulging disc. The pain actually comes from the back of the disc, specifically a tear in the back of the disc. I'll be there, thanks. The tear is called an annular tear, and when it happens in the back of the disc, it's called a posterior annular tear. Posterior as opposed to anterior or lateral. Anterior annular tears and lateral annular tears do not cause any pain or symptoms. And herniated discs to the side of the spine or in the front of the spine don't cause any problems. We leave them alone. So the only kind of herniated discs that cause symptoms that we need to deal with are like this video is showing. Right now, the animation shows a tear in the back of the disc. It's called a posterior annular tear. And when the jelly, the blue stuff, pushes through that, that's the herniation. So the first step is always an annular tear, then a herniation, and then over time, inflammation sets in with the pink reddish tissue that's inflamed, and that is painful tissue, that inflammatory tissue. If you've ever had a pimple or any inflammation in your body, you know inflammation is painful. So it's no different in the back of a disc when you get inflammation like you do with a herniated disc in the back of the disc. You're going to get pain in the neck. It's going to affect the nerve roots like it is right there, spreading the inflammation on the nerve root, and that's going to affect the motor and sensory branches, and that can affect the strength in your arm and the sensation in your arm. So you're going to feel like there's pain down your arm. You may get weakness in your hand. You may get numbness in your arm or hand as a result of that herniated disc as well. So what we do with the Deuk laser disc repair, we're going to go in, we're going to find that tear, and we're going to use a laser to remove the herniation and clean up the tear so that it will heal itself. Okay? And that process is done minimally invasive. It's the least invasive, smallest incision surgery in the world for the spine. There is nothing smaller. It's literally just barely bigger than a needle. And needle surgeries are not really considered surgeries. They're called interventional pain management procedure. They're done by non-surgeons or interventionalists. So a needle is the smallest incision that you can make in the skin, and those procedures are called percutaneous. The next size up is the couple of millimeter incisions with the Deuk laser disc repair endoscopic surgery. Now the other credit I have to give is to the South Koreans, Dr. Sang-Ho Lee. And Dr. Sang-Ho Lee is a pioneer in endoscopic surgery, and he is not a pioneer in lumbar surgery. He's a pioneer in cervical spine surgery. So he was one of the first in the world to go into the neck and go through the disc, leaving the normal disc alone, and just get to the back there and remove the herniation. But unfortunately, that's where he stopped. And he contributed a lot to the technique of getting to the back of the disc and removing herniation. However, the debridement of the annular tear to allow it to heal properly and get the herniated disc that stuck to the annular tear out was my creation. And that's why I was the first to publish annular debridement in the world, and it was published in the Surgical Neurology International Journal, which is an open access journal. I chose to publish it there because open access was coming around at the time in 2012 when it was published about 10 years ago. And open access allowed everybody to read the article and learn about this new technology without having to pay for it. Closed access journals require a payment of about $100 per article view, and most people aren't going to spend $100 to learn about advances in spine surgery. So I wanted to make sure that the article is free to people, so I paid for its publication myself, and not paid for publication, but paid for the fees that cost once it was accepted by the editorial board and the chief editor, Dr. James Altman. I can't remember his spelling of his last name, but he was the editor-in-chief, and I think he still is, Osman. And Dr. Osman is a professor emeritus neurosurgeon who was at UCLA as a professor, and he's retired now, but he is the editor-in-chief of Surgical Neurology International at the time that I submitted my research and work for publication, and it was accepted for publication, and it was peer-reviewed and published. So I chose an open access journal that allowed people to have free access to that papers that I published, and there's 2 of them on the Deuk laser disc repair so far that have been published in Surgical Neurology International. Now I have other publications as well with the Congress of Neurological Surgeons, the American Association of Neurological Surgeons, the Society for Minimally Invasive Spine Surgery, and the Southern Neurosurgical Society. So I have publications as well with them, but those are not available to the general public. They were included in the meetings where I presented my research and my work to other neurosurgeons. Long story short, the Deuk laser disc repair procedure is peer-reviewed and published. It has been FDA approved with all FDA-approved equipment. So the surgery you're about to watch today is a surgery that I have been performing at Deuk Spine Institute now for 15 years, and we've had 0 complications, surgical complications, from my surgery side. We've had 1 anesthesia complication in 15 years, and right now, basically, we're getting ready to do about 1,401 surgery. I've done over 1,400 of these surgeries. I've stopped counting officially, and this is somewhere just above 1,400. So we'll call it number 1,401. I would like to say that the most common endoscopic Deuk laser disc repair surgeries I've performed are in the lower back, lumbar. The second most common are cervical, like we're going to watch today. And we've just started doing thoracic Deuk laser disc repairs just about 2 years ago. And I think we've done 12. We have somebody else coming in who's going to eventually be number 13, and maybe even a 14 coming up soon. So keep your eyes open for the thoracic Deuk laser disc repair. Those are special, and those are I started doing relatively more recently in the last 2 years. But again, we are the first in the world to do transforaminal thoracic disc surgery endoscopically, minimally invasive. All of our surgeries are done outpatient. These patients literally go home an hour after their surgery. 1 hour after surgery is done, they go home. And they go home awake, walking, normal, neurologically. It's an incredible surgery. You won't see results like that with any other surgery in the world. So, without further ado, we will get started. I'm going to turn the mic and the video platform back over to Diego, and I'm going to go scrub and get into the operating room where we'll join you again for this 2-level cervical Deuk laser disc repair.
Thank you very much, Dr. Deuk. And guys, remember to type up your questions into the chat. Dr. Deuk will have the ability to answer them live during surgery. Meanwhile, I'll leave you with some testimonials, and I'll see you very soon.
I have a very special patient sitting here next to me who's traveled all the way from Tennessee.
Yes, sir.
With his family for one purpose, and that is to get his neck fixed.
In the wild, I've trained animals for 25 years, not jumping through fiery hoops, but just mostly behavior, come is, just a few words. We had 52 big cats, tigers, lions, leopards, cougars, lynx. This is me about 6 years ago in the tiger cage. And this guy here, we raised him from a baby.
That's special.
I'll tell you what, the special part is being here.
And how long have you been dealing with this problem with your neck?
It's come on in the last 8 weeks strong, but after I start thinking about it, even 6 months ago, I was seeing things happen that I couldn't understand why. And I just want to get back to somewhat where I was at and get the feeling back in my hands, my stability, a little strength where I can get this boy up.
Well, what's going on, as we've talked about, is you've got these herniated discs, bone spurs in your neck that are pinching down on your spinal cord and nerves. And I'm going to go in there tomorrow with a laser, and we're going to open all those spaces up, get the pressure off the spinal cord and the nerves, so you can start getting some feeling back and strength back in those arms.
That sounds great. That's why I'm here. Then I've researched, and I kept coming back to you all and seeing the testimonies and watching hour after hour after hour of the surgery. And that says a lot if you can do it live on Facebook. It's just a pleasure to be here. I feel safe. I feel like when we arrived last night, we drove up in front of the place, and I told my crew and my wife and my driver, I said, we have arrived. We have arrived. Thank you so much.
We'll see you tomorrow morning, all right?
I appreciate it so much.
We did surgery yesterday with the laser. Everything went really well. You can actually see the 4mm incision right there, 3 discs. He didn't want fusion, and so he found Deuk Spine Institute and he came here.
After the surgery, when I talked to her, I was still a little bit drowsy. And 4 hours later, we were sitting over at a restaurant, seafood restaurant, eating seafood, and I could clap my hands at the baby because he claps when he does something good. And I could clap with him without missing my hands.
And you're already getting strength back in your arms and legs. You're getting control of your bowel and bladder back again. That's great news. It's a great sign. I think you're going to keep improving and hopefully get you back to normal.
You are the best. That's why I'm here. That is why I'm here. It is amazing. From the time I walked into this place, I felt at home. I felt like I was with friends all the way through surgery. When we walk into this surgical room, everything's so clean. I feel like I'm in a dream. I really do. Thank you so very much for what you've done.
You are welcome. Dr. Deukmedjian. We're here with one of our patients who traveled to here from Texas, correct?
No, Auburn, Alabama.
Sorry, Alabama. All right, so Alabama. And why did you come to Duke Spine Institute?
Because the last flare-up of L4 that ruptured in 1999 was unbearable, and my wife can be a testament to that. Who took care of me for 10 days, crying on the floor with an amazing, incredible pain.
Okay. And you've had that pain now in your lower back for 22 years.
Yes.
You've tried physical therapy and exercises, stretching, but none of those things worked.
No, temporarily.
Yeah. And where was your pain coming from? Do you know?
It was around the belt region in the back. Yeah.
So the L4-5 and L5-S1 discs had tears and they had inflammation and pain. He also had sacroiliac joint inflammation and pain. And Dr. Patel standing here, which we don't get to see you very often, but Dr. Patel was a hero. He came in and did the bilateral SI joint injection.
Yep.
So do you still have the pain in your back that you came here with?
No.
It's gone.
It's very, very gone. Yes.
Excellent. Well, it should stay gone. Is there anything you want to say to your audience?
Well, I think more people should come and start looking at this procedure, finding the website, learning about what are the things that needs to be done, such as sending the MRI, and trust on the incredible treatment and experience that I have received from this team. It's relatively impressive, very impressive, and I would recommend it to many of my friends who play golf and has been suffering for a long time.
All right, very good. Well, have a safe trip home.
Thank you.
Finally, this is 1 hour after my procedure, and I am walking the spine. I'm gonna turn, very stiff, and then I'm gonna walk around, and so far so good. I feel very, very pleased. 24 hours after the procedure was performed on me on L4, L5, and S1, the L4 injury has been there for 21 years and has never give up and has made my life miserable. And the initial injury occurred because I have congenital issues inherited from my father, who suffered tremendous sciatic pains, and all my five brothers also have the same issues. So this is only 24 hours after. I already walked a mile this morning, and I only have taken 1/3 of the indicated medications, and I still have no pain, with considerable improvement over 3 or 4 major landmarks. The first one is pain down the leg, the right leg, where the main injury occurred, as well as pain on the left and the middle of the back for the 2 main new discs that were also injured, the L5 and the S1. So I recommend this procedure to anyone who, like me, has suffered for many years and were afraid to the pain that is inflicted with some other technologies that basically requires months for rehab. And I will not hesitate to submit myself to another procedure if it's needed, Dr. Duke's Spine Institute. So I thank everybody for all the service, outstanding service, medical and social.
Hello everyone, Dr. Deuk is still scrubbing up. He will start his surgery real soon. Meanwhile, we will watch another video about how great the Duke Spine Institute is. Meanwhile, you guys can type up your questions for Dr. Deuk. He will be ready real soon. Thank you so much for your patience.
The pain level got to about an 8, a 9.
The right side of my body from the waist down was pretty much useless and in pain constantly.
The pain was chronic.
It was an aching, stabbing.
It became unbearable. It became where I didn't want to get out of bed. I didn't want to talk to anybody. I didn't want to do anything.
I had the pain every single day in my low back.
It's torturous. I can't go to sleep at night. I can't lay down. I can't sit for too long. Can't stand for too long.
I couldn't sit. I couldn't stand. I couldn't walk more than 50 feet.
It's excruciating.
Sends excruciating pain across my back. Gets down to my hands where my hands are numb.
I had no life.
If you are suffering from neck or back pain, the Deuk Spine Institute can give you the relief you need to live your life without pain.
Now I have absolutely no pain.
Not even 24 hours after the surgery was complete, I was able to be how I felt is normal. And it was good.
No scars, didn't hurt at all. As you know, when I woke up, it was totally painless.
The next morning, I was up and about and out, dressed on the job.
I have no pain. I'm living my life and doing great things, and I'm just very happy.
It's a great feeling not to be in pain.
Deuk Spine Institute has changed thousands of lives. Isn't it time you live your life pain-free? Log in to deukspine.com or call 1-800-FIX-MY-BACK for a free MRI review and consultation.
I feel like a new man again.
And it's thanks to Dr. Deuk. He gave me my life back.
Dr. Deuk did an amazing job fixing my back. I recommend him highly to anybody who has any kind of back issues, any kind of back pain. Don't wait. Go see him. The relief is amazing.
All right, Dr. Deukmedjian AP, and we're getting ready to place our percutaneous spinal needle shot, just a quick shot. It's a quick AP, not a detailed AP. All right, and shot. All right, give me a lateral view now. Do you have a tube in, esophageal tube in? You do? All right, good. Lateral, go. Shot. 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 Hold on. Shot. AP quick. That's a quick AP. Now. Looks good. Lateral. Okay, shot. All right, so 2, 3, 4, 5, 6. Let's get another AP, and this is a take your time, get a good picture AP. And I think we got some rotation on the spine, so we got to take that into account. Shot. Hey, we're right in the middle. That looks pretty darn good. All right, very good. I'm happy with that. Let's go back to a lateral. Take. You can see the esophagus is deflected way to the side. You can see the endotracheal tube, it's deflected to the side, opposite of me. And what we're doing right now is I'm just getting the access to shot to the disc space, the bottom one that we're going to be treating today. Shot. You can relax. You can relax. Shot. Thanks. All right. So give me an AP. We're in the 2, 3, 4, 5, 6 disc space, just above his prior fusion. Yeah, that looks good. Give me a straight AP, please. Get the spinous processes lined up. A little better than that. Keep going. Yep. All right, so the tip of my needle is in the disc space above the fusion. His prior fusion, you can see a metal plate with screws. That's not what we're operating on. We're not operating on the prior fusion. We're operating on the discs, 2 discs above it. So the one directly above and the one above that. And the spinous process is directly in the midline. So I'm happy, and the needle is lined up with the spinous process. So we're exactly where we want to be at the front of the disc. Give me a lateral. And as I said earlier in this recording, the first part of the surgery is gaining access to the disc safely, which I've done. The problem is that my needle is flush with the superior end plate of C6. So I'm not going to be able to do a discogram as such, unless I back out a little bit, which I'm going to try to do, and try to angle it more north. Shot. Shot. And I'm going to try to redirect this thing and go further north. Shot. Yeah, and it doesn't want to. So I'm still going to try to do my discogram. I need the discogram to be done so I can see the inside of the disc, what it looks like. Plus, I'm going to be putting some blue dye in there. The blue dye, shot. Let's see, give me an AP. All right, Coker. It's almost like a vertebral bodyogram. Maybe in the actual vertebral body, which is okay because I'm entering the disc in the right place. I just need to angle it, which I can't do with the needle because of all the scar tissue from his prior surgery. All right, go back to a lateral. So yeah, that's what I'm going to do. I'm going to go ahead and gain access to the disc space using a guide wire. So you see I've taken the center of the needle out, placing the guide wire. Lateral shot. How's he doing? Everything okay? All right, so guide wire will go in, shot. And like I said, the guide wire tip is probably sitting in the C6 vertebral body, the top, the end plate. But there is a shape to that, shot, where it's kind of concave at the top of the end plate. It kind of goes down in. So it's probably sitting right on the end plate, but I'm not able to get the dye to go into the disc properly. Shot. So now we have the guide wire there. I'm happy with where the guide wire enters the disc. It's at the bottom of the disc. I'll do a little local injection in the skin. Our incision will be 4 millimeters. Injecting local, 1 cc. Now I use an 11 blade, and I'm going to basically make a 4 millimeter incision. The entire surgery will be done with this tiny little 4 millimeter incision. We call it a stab incision. There we go. We've lost 1 drop of blood. How many drops in a milliliter? Anybody know? 20. 20 drops of blood make up 1 milliliter. We've lost 1 drop. Shot. Now I'm going to advance this dilator down so you guys can see. Can you all see this, Diego?
Yes, we can.
We're advancing the dilator down. Past the carotid, shot. Past the jugular vein. Right to the front of the spine. This is a 3 millimeter dilator, shot. So it's super tiny. It's almost like putting a needle in. Now I already know that I have a safe path to the spine, And this is what other spine surgeons can't do. They've never done this, they can't do it, they won't do it, they've never been trained to do it. But this is what I learned from the Korean surgeons, how to get here. Okay, and they've done it many times. They taught me to do it, and that is to go from here with a small incision down to the spine. Okay, but there are 6,000 spine surgeons in the United States, and none of them know how to do this, except me. So this is futuristic technology here now, and we've been doing it for 15 years. That's what's sad. Unfortunately, other surgeons will never learn this because it's not being taught in their training centers where they train. Okay, but I had to go overseas to learn. This is being done in other countries like China and Korea. Maybe Germany has 1 or 2 surgeons, but not more than that. So it's very rare to find a surgeon who knows how to do the surgery. And this, what I just did, is probably the second hardest part of the whole surgery. How's the blood pressure? So 2 drops of blood. Shot. All right, at this point, I'm going to remove the guide wire, but I want to get a quick AP, Coker. I want to make sure the tip of my dilator is sitting in the front of the spine, like in the middle of the front of the spine. So the front of the spine is a pretty big area. You want to enter the front of the disc through the middle, the midline area, okay? So that's perfect. You can see the spinous process right above that guide wire. Point to the spinous process for them so they could see it. There it is. Just go right there, right there. A little higher. It's like a little hat right there, like right there. Yes, Napoleon's hat. That's the spinous process. And the tip of my dilator at the front of the disc is right in the midline, just above the metal plate. So it's perfect. Lateral. Nice job, Jordan. So at this point, I'm happy with where my dilator is going to enter the C5-6 disc. It's in the midline. And for those of you who don't know, the front of the spine right there has a ligament that runs up and down the whole spine, from the neck to the tailbone. It's called the anterior longitudinal ligament. And I'm going through the anterior longitudinal ligament, passing through it, spreading the fibers, not damaging it, into the disc. So you want to be the width of the ALL. You want to be either to the right of the center or to the left of the center, but you don't want to get into the muscles on the side of the spine. Those muscles are called longus colli muscles. You don't want to be in the longus colli. If you're in the longus colli, then you can damage the sympathetic trunk, shot, and you can also have issues with bleeding. Shot? So you don't want to damage the sympathetic trunk, and you don't want to have issues with bleeding. Okay, I'm advancing my dilator through into the disc. Shot. I am inside which disc? Does everyone know? Can you guys count? So there's number 2 at the top. Show them number 2. C2 is right there. C3, C4, C5, and C6. Good. So we are at the C5-6 disc. Guide wire. I'm going to do a discogram now inside the disc. Okay? So I'm inside the center of the C5-6 disc with my dilator. I'm going to do another discogram. And this is not an evocative discogram. We call this a chromo, spelled CH, shot, CHROMO, chromo, which means color, shot, a chromo discogram, shot. And why do we do a chromo discogram? Is that it right there, shot? Trying to clean the disc material out of the tip of this thing. All right. No, I need the needle. So we want to do a chromo discogram. That's not the right needle, guys. Come on. Luis, you should know better than that. It's a skinny needle.
That's a skinny one.
No, it's not.
Yes, sir. That's a 22.
That's the one I used to do the procedure. Anyway, chromo discogram means color, shot. And the color is the blue dye that we use, shot. All right. So it's still not coming out. Let me have the guide wire. Shot. All right, good. Now it should come out. There's a lot of scar tissue, by the way, at the back of this disc. Anybody know why? No. From the herniated disc itself. Herniated discs cause inflammation. Inflammation creates scar tissue. I can't get any out. Shot? All right, so we're stuck not having a discogram here. Mallet, I'm going to advance this further forward. This disc has tremendous inflammation in it, in the back of it. Shot? And shot? 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 Just about there. We're inside the herniation right now as we speak. We're inside the annular tear with the tip of that dilator. Why don't you go ahead and run the video showing, we've lost 2 drops of blood. Run the video, Diego, showing why herniated discs cause pain and inflammation.
Okay, they're watching the video.
Traumatic injury on the disc can cause annular tears to form.
In the meantime, we're going to put this tube down and get started. Shot?
Pressure on the disc causes herniation of the nucleus pulpus through the annular tear. Inflammatory tissue develops within the annular tear, causing neck pain. The inflamed annular tear generates pain signals. Additional injuries can cause worsening symptoms. Inflammation from the annular tear can spread to the nearby nerve roots, causing arm pain. Pain signals travel up the nerves to the brain, causing localized neck pain. Pain signals reach the primary somatosensory cortex, causing conscious awareness of neck pain. If you have a herniated or bulging disc and neck pain, submit your MRI for a free review at www.mri.deukspine.com.
You're live, Deuk.
All right, your voice is barely audible, Diego, but I heard you. I think we're back, right?
Yes, sir.
Okay, folks, so what have you missed? Nothing really. I've just advanced this tube. It's a 4mm tube down along the dilator. So now take a shot. You got it? Go ahead and show the x-ray there. And look at the arrow. The arrow is going to show you the end of the tube. I'm going to do the whole surgery at the end of that tube there. Yep. And the tube is not taking the disc out. Show them where the disc that we're leaving. We're leaving all that disc there. We're not touching it. We're just spreading it apart. So we're creating, like Moses parted the Red Sea, we're parting the disc. Okay? You can call me the Moses of discs. All right.
Right here. Look at it. It's right here.
Long story short, we leave that disc there. Therefore, when we're done with the surgery, which is the part in the back of the disc, we don't need to put a cage because we didn't take the disc out. The disc is taken out by all other spine surgeons in the world that don't do endoscopic transdiscal surgery like I'm doing. In other words, of the 6,000 spine surgeons in the United States, all 6,000 take the whole disc out, except for orthopedic surgeons that don't even take the whole disc out, and they're supposed to. They just fuse. They take the front of the disc out, which is not doing you any favors. Trust me, you want that disc out. If you're going to take the whole disc, take the whole disc. Don't just take half the disc. I see people all the time have ACDF surgery, and the surgeon doesn't take the whole disc out. They just take a front part of it out. And the patients still have pinched nerves. They still have arm pain, neck pain, headaches, etc. And that's because their surgeon never took the front of the whole disc out You've got to take the whole disc out to get to the part in the back if you're not doing endoscopic surgery like we are. Okay? There's the laser. It's at about 12 o'clock. Okay, you see that? And we have a light source, and there is our herniation. We're inside of it. We're going to start taking the herniation out from the inside out. I'm going to improve the focus just a little bit there, and we're going to get started. We're on 20? Yes, sir. So we're using a holmium YAG laser, a medical laser. Somebody wrote last night in Facebook, lasers are only good for soft tissue. I'm like, no, they're not. They cut steel. I don't know if people are aware, but lasers are used in the automotive industry and in the steel fabrication industry to cut steel. So this whole idea that a laser could only cut soft tissue is just crazy. We use the same type of laser that can cut steel here. So why is it safe? It's safe because the laser only cuts 0.5 millimeter from the tip of the glass tube. So as long as I can control the glass tube, we can do a safe surgery. Does that make sense? And I can see the tip. I can see what I'm zapping. That's a bone spur, by the way, in case you're wondering. But we've got a lot of work to do. You can see that's a herniated disc right there that just floated up. And this is all part of the herniation and bone spur. So if you don't think lasers can get bone spurs, those are bone spurs right there. The golden color stuff, very easy to get bone spurs.
Dr. Deuk, are you ready for some questions?
What is it?
Are you ready for some questions?
Honestly, your voice is so low, it's like a mouse.
Dr. Deuk, can you hear me better?
Yeah.
Okay.
Better.
Are you ready for some questions?
I am. That's a little bit too loud. I would tone it down just 30%, maybe 20%.
Okay, understood.
I'm ready for questions.
Our first question comes from Facebook.
That's too much toning down.
Okay. Our first question comes from Facebook. Why are the thoracic DLDRs more difficult?
Why are thoracic DLDRs more difficult?
Mm-hmm.
It's because a thoracic DLDR is being done in a part of the spine that has a lot of delicate structures nearby. For example, there is the aorta and the lungs and the spinal cord, and all those things are super delicate, and they're really close to where I'm operating. So it's really hard. You can't move them. Like, you just saw me at the beginning of the surgery. What did I do? The first thing I did was I moved the carotid over, and I moved the esophagus over, and I moved the trachea over. All that done with my hand, pushing externally on the skin. I was able to move all that stuff over, okay? Well, I can't do that in a thoracic. You can't move anything over. You gotta work around it. You got to basically live with whatever's there and deal with it. All right, I got a little piece of the plastic coating on the laser just sticking off. So I need that fixed because it's affecting my view. Let's get this off and let's fix it. All right. Great question, though. That's why thoracics are harder to do, because the lung cannot be moved over, the aorta cannot be moved over, the lymphatic system cannot be moved over. Nothing can be moved over, basically.
We have another one.
Uh-huh.
One patient on Facebook sees that this patient had a previous fusion.
That is correct.
Is this procedure necessary because of adjacent disc disease?
Yes, that's correct. This patient has now herniated discs above his fusion. Can you have the light on, please? He has herniated discs above his fusion, and they are affecting his arm. Like, he cannot use his arm normally. He's losing strength in his arm. And because of that, he needs to get this fixed. He's kind of waited too long. But that said, He's waited longer than I would recommend, but at this point you can't go back and undo what's already been done. From the time he came to us to the time we're doing his surgery is quite literally, I want to say, laser on, like 2 weeks. So we had to do a bunch of tests and stuff, maybe not even 2 weeks, maybe it's been 1 week, I don't know. I got to go back and look at it, but you know, people that have herniated discs honestly should not be waiting. If you've got a pinched nerve and your doctor tells you leave it alone, wait till you're paralyzed, don't listen to them. That doctor is wrong. You know? I'm sorry, but they're wrong. That was the old way of thinking about spine surgery when, you know, spine surgery was far more dangerous and the results were far worse. But now the surgeries are far more predictable. And again, it's not every spine surgeon that can do that. You have to find the right spine surgeon. There are still spine surgeons out there, many of them, that really are not that good, you know, technically with their surgery. And so what they do is they really have a high complication rate and a very low success rate. By the way, this is all bone spur here. I'm removing to get to the foramen and get the herniations out. But you can start to see some mobilization of the actual joint. Not just my endoscope is moving. I need to kind of come back and look at the more middle area of the disc, like right over here, in order to remove some of this. I'm going to have to turn my scope around. But so the viewer who asked, is this adjacent segment disease? The answer is yes. I did not do the original fusion on this patient. If you notice, the metal plate is too long. I would never have put the metal plate that long. I think the metal plate should have been a lot shorter, but I didn't do this patient's fusion. So the problem is when you get a metal plate that is so long, you encroach on the disc space above or below your fusion. This is what's hitting on the nerve right here. All this grungy material. This is in the back of the disc. These are all bone spurs and they're kind of blocking me from gaining down to the nerve root, so I've got to deal with them. But I'm trying to get some more of this. This is a lot of scar tissue. This is a lot of chronic disease. By the way, this is important. If you have a herniated disc, get it fixed if it's symptomatic early. Because what's happening if you don't is you're allowing the joint to be destroyed. Okay? And the way you fix it is what you're seeing right now, the Deuk laser disc repair. It's quite literally the only way in the world to repair a herniated disc and stop the disc from getting worse. Now, why do I say that? Because what destroys these discs and causes it to collapse and turn dark and spondylitic is inflammation. And nobody's really understood that until more recently when we discovered that, and now people are starting to understand it in the field. Inflammation is the cause of the damage to the disc that causes degenerative disc disease. There's lots of studies to support that. We now know this is an inflammatory problem. And as such, you have to get rid of the inflammation. And by the way, this is not the only inflammatory condition in the body. There's lots of inflammatory diseases that destroy our bodies. It's just now we're starting to learn that and understand it. Okay? So this disc is destroyed by chronic inflammation. When you have pain in your neck, it's a sign there's inflammation. The best thing to do, get an MRI, see if there's a herniated disc, the source of the pain, source of the inflammation. Remember, it's going to be the annular tear where the inflammation is occurring, or the facet joints. But that's something that an astute doctor can figure out. And once you've identified the source of the problem, then fix it with the Deuk laser disc repair. Again, this is the only surgery in the world that can prevent degeneration of a disc without actually removing the disc and fusing it or putting an artificial disc in there. And those really aren't preventing degeneration of the disc, they're just treating the degeneration of a disc. Does that make sense? So again, I've had to remove quite a bit of scar tissue. That's this stuff right here, and bone spur. And I'm just trying to work my way down to the foramen and get that nerve root completely decompressed. There's another bone spur there. And of course, bone itself is what bleeds in this situation. Another piece of herniation there. So, will this disc ever look normal again? The answer is no. It will never look normal again. We're not trying to make discs look normal. We're trying to eliminate symptoms and signs like weakness. That's my goal here. So, what are the symptoms and signs of a herniated disc? Neck pain could be. Arm pain, weakness, numbness, paresthesias or tingling in the arms. And what else? You could have headaches. You could have balance difficulty if it affects the spinal cord. You could lose control of your bowel or bladder if it gets worse. So you want to preserve function, like strength, feeling. You want to restore function as much as you can, but it's not always possible. Really, the goal here is to keep the patient from getting worse. Any restoration of function. So keep the patient from getting worse is called preservation of function. And get the patient better or restoring function is restoration of function. So one of the goals of the surgery is preservation of function. And another one is restoration of function, obviously, if you can do it. And then, of course, we're eliminating neck pain. Those are pieces of herniated disc right there that were pushing on the nerve. And we want to float them out. They keep coming out of that crack, just little pieces. And the important thing here is to note that, herniated discs don't come out as one giant piece most often. They come out in multiple pieces. A lot of people think, oh yeah, it's one big piece. But the reality is that herniated discs are episodic. They happen as episodes, and episodes over time. So don't expect all of it to come out as one piece. You'll be disappointed. Sometimes we see that, but it's not often. All right. So I've been working in his right foramen, primarily here, and I'm not seeing any more herniated fragments. Just a lot of scar tissue down there. I'm going to try to get what I can while I'm here, because I know that scar tissue is caused by herniations. Okay? We're going to go back and look at the other side again. Thanks. Yeah, I appreciate it. Thank you. Yep, thank you. Again, this disc is on a scale of 1 to 10. This is degenerated to a 9 out of 10. And I wish that this patient would have come to me years ago when they first started having problems. Okay? Because years ago, all this degeneration could have been prevented. And that's the main message here, folks. We were never able to prevent degenerative disc disease because we didn't understand what caused it. There was a lot of speculation, and there still is, by the way. A lot of doctors still don't know what causes it. They haven't figured it out. But we figured it out, and it is an inflammatory destruction of the disc. And the inflammation comes from the annular tear and herniation. So if you can go in and stop the inflammation in the tear, which is what the Deuk laser disc repair does, and it's the only surgery that does it while still preserving the disc, then you can stop the degeneration from happening. You can keep a relatively normal disc, basically. All right. I'm going to go and reposition my tube a little bit and look laterally and try to get more out here. So I'm just working my way laterally, and this is all scar tissue here, by the way. All of this, herniated disc plus scar tissue. This is the annular debridement that I'm talking about. And this is the foramen, or just the back of the foramen I've been working on. This is on his right side at C5-6. This is not surgery for the faint of heart. In other words, this is very complex surgery. I make it look easy because I've done so many. I've done now probably 500 cervical lasers patients, and in those 500 I average about 2.5 discs per patient. So that's, imagine that's 1,000 cervical discs that I've done. Okay, and that's a lot. That's 1,000 more than 99% of spine surgeons. And so I have a comfort level of doing this that other surgeons don't have. Okay? And they will never have in their careers because it takes years to get this kind of cases done.
Hello, Dr. Deuk.
Yep.
Do you have time for a question?
Sure do.
Okay.
Yes.
On Facebook, they want to know, what does it mean when the derna is burning?
I did not hear the question.
The
What
derna is burning? What does that mean?
The what is burning?
Derna.
The dura?
Yeah, dura, yes.
The dura is burning?
Yes. What does that mean? They want
Well,
to know.
who said the dura is burning? I don't understand that.
Oh, no, just a question on Facebook wants to know.
I'm not sure what dura is burning means. The dura is the covering around the nerve root. It's inflamed means inflammation on the dura.
Oh, okay.
And that comes from the inflammation that we're treating here. There's a bone spur right on the nerve root in the foramen. Just got rid of it. Really not seeing much in terms of a herniated disc anymore. There's just a bunch of scar tissue and thickened ligament right here. That ligament that's thickened is called the ligamentum flavum. It runs out into the foramen, and it's sitting on top of the nerve, squashing the nerve. And that's what I'm cleaning up. So at this point, it's not even a disc herniation, it's thickened ligament from scar tissue and inflammation of the ligament over years from that inflammatory process. So I want to try to get as much of that out of there as I can, especially on this side, since this is the side that was really bothering him. That's all scar tissue right there. That is the annulus, the annular tear full of scar tissue. And that scar tissue gets so thick at times that it can actually pinch the nerve. And that's what's happening in the foramen here. It's a combination of thickened ligament, herniated material, and scar tissue from the annular tear, from chronic inflammation. You ever get scar tissue in your body and you can feel it under your skin? There's like a knot there. That's what we're doing right here. This is a knot that's literally in the spine, right above the nerve. Look how beautifully the laser deals with that scar tissue and the bone spurs. Just, it melts it. And these are all pieces of herniation right here coming out. Okay? Almost done here. I'm loving it. I'm getting a good result. Nice and deep. Great questions from our audience, by the way. So the laser is the little thing with a red tip. It looks like a glass tube. That is the laser fiber. It's not the machine that creates the laser energy. It's a fiber that transmits the laser energy down to the back of the disc where I need it. It's a fiber optic cable. And this is basically fiber optic surgery. Okay? Because laser is a type of electromagnetic radiation. So it travels in waves like light does, but it's more energetic than light in many ways. And this is the same thing. If you look at those transatlantic cables that transmit fiber optics and broadband from one country or one continent to another, that's what we've got here. We're basically sending fiber optic signals down, which are very powerful and are blasting this tissue and getting rid of the scar tissue, getting rid of the bone spurs, getting rid of the herniated disc, and getting rid of the annular tear that's just junked up. So, pretty cool use of fiber optics, huh? All scar tissue here from the annular tear and the herniated disc. This is years and years of degeneration and inflammation right here. Years. If only this could have been stopped years ago. That is the foramen once again. That's where the root was being compressed. There's nothing in there now. Just I cleaned it all out. We're pretty much ready to finish up here. Just want to take one more look. Make sure I get everything.
Dr. Deuk, we have a question from YouTube.
Sure.
Do you only work in Florida or do you have any other locations?
Yeah, Deuk Spine, just so you all know, is kind of a mom and pop facility. I started it with my wife, 2004, in Florida. We don't have big money backing us. We don't make enough money to have multiple locations, to be honest with you. We're not a big corporation. We're pretty much just. When I started out, Deuk Spine, I had $250,000 in debt. I had no money to my name. So, you know, we're lucky to have what we have here. It's just one building. And we're located in Melbourne, Florida, right where SpaceX is, by the way. And right where Blue Origin is. So we're in I think, one of the best places in the world. Obviously, we're not launching rockets, but this is a very technologically intensive area with the futuristic technologies, and that's what this is. It's a futuristic technology. So no, we don't have multiple locations. This is our only location. Patients travel here from all over the world to get this surgery done because nobody else does it, and it's worth it. If you're in pain, if you're looking at having a fusion done, don't do it. You know, get it fixed with the laser. All right, pretty much done. Done. All right, so we're gonna move from this disc to the next one. That's my least favorite part of the surgery. It's the hardest part of the surgery. All right. Just putting a little antiseptic in. The antiseptic is betadine. Betadine is essentially developed by NASA just down the road. Whatever, I don't know. I need the regular needle. I'm taking this out. So betadine is an antiseptic. It was developed by NASA basically to kill any space germs that the astronauts might bring back. More irrigation. And it's used everywhere around the world now for surgery. So we're no exception. Take. And what's oozing here is essentially the bone. You remember the bone spurs I took? Well, they leave little stumps of bone, and those little stumps of bone, actually, let me have that. Those little stumps of bone that are left, they bleed. So a little bit of blood. We've probably lost 5 cc's maximum. I'm going to take the tube out. I'm leaving the dilator. And we are, remember, we're at the C5-6 disc. This is a 2-disc surgery. So we're going to do the 4-5 next, the one above. This patient has herniated disc at C4-5 and C5-6. Both discs are above his prior fusion. And we're going to take an x-ray image in just a second, and you'll see that there is indeed a fusion that he had done years ago. I can't remember when his fusion was. I want to say it was in the 80s. I think it was in the 80s, but I'm not sure. But this shows you that we can do the Deuk laser disc repair endoscopic transdiscal surgery in the neck or back adjacent to a prior fusion or artificial disc. So if you have had prior surgery, don't worry, you can still do this Deuk laser disc repair. I just need to look at your MRI, CAT scan, and make sure that it's safe to do and that we'll be able to access the disc base. So it's, people that are interested should always submit their MRI for our free review. We do a free telemedicine consult for 15 minutes on Zoom, and there's no obligation to treat with us whatsoever. If you just want answers, what's going on with my neck, my back, is there something fixable? What's it going to take to fix it? What's the best surgery to fix it or best treatment to fix it? That's what those consultations are, and they're free. Okay, we're going to move from this disc that we're in now up one. All right, so here we go. And this is, in my opinion, the hardest part of the whole surgery. Shot? This is going to take the most amount of training for anyone that wants to learn this. And this was developed at Deuk Spine. Shot? By me. Everything okay? Oh, yeah. All right, I want to get an AP. I want to make sure I'm in the middle. So when you come out of the disc space, there's a tendency for the dilator to move left or right. And you want to make sure you stay dead center. Dead center is perfect. We're there. Go back to a lateral. Nice job there, Jordan. So I'm keeping my tip pressed against the front of the spine, and I'm just going to march my way along the ALL shot right up to the next disc. Okay, and I'm going to stay in the midline. Shot. And there we are. Shot. I'm happy with that, but I want to make sure I'm good on the front, on the side-to-side thing. So you got to get an AP, anterior posterior. Shot. So I'm sitting right over the next disc, sitting up against the ALL, anterior longitudinal ligament. Perfect. Mallet. And now I'm going to go back to a lateral view, and I'm going to enter the disc, the next disc in the middle, because the tip of my dilator has not lifted off of the spine, not once. Shot. Okay. So because I haven't lifted off the spine, shot, I'm able to safely move to the next disc. Shot. Man, I could feel a ton of scar tissue here as well. Now this isn't as bad, okay? And I think we'll be able to get a discogram done. Now this disc, hopefully we'll be able to do a discogram. There won't be too much scar tissue because it's the scar tissue in the disc from the herniation and inflammation for years that basically prevents me from doing the discogram. Perfect. Take. Let's see if we can get a discogram this time. Shot. Shoot. Shot. Hey, we did it. All right, so nice thing. Give me show them the dye leaking out and give me an AP. Coker. Yep, there's the dye leaking out. There's the herniation. You can see it. It looks like a, there's only one thing that comes to my mind, but I can't say it. It looks like a half of a basketball. I need to come up with something. All right, so some of the dye has already dissolved away or been carried away by the bloodstream or tissues, but you can see the tears in the back of the disc. And you can see how my dilator is off to the patient's right, which is where most of their arm symptoms are. You can also see show them the esophagus. See the esophageal tube? It's the braided one. Show them the braided. That's the esophageal tube. It's a temperature probe in the esophagus. So you can see where we've pushed the esophagus way away and staying away. Show them the endotracheal tube, which is in the trachea. Very good. All right? So I've displaced those. And our patient's going to enjoy watching his surgery because I'll give you a little secret. He's actually a doctor. He's actually an anesthesiologist. And he knows that he doesn't want another fusion. So that's why he came to Deuk Spine for this surgery. Shot. Shot. So we're at the back of the disc, 2, 3, 4, 5. Shot. I'm right at where the herniation is. That's it? It's not really going anymore. Shot. It's like it doesn't want to, and that's fine. Though I would like to get it out a little more into the herniation, just a little bit more. Maybe off to the side a little. Shot. That's better. Shot. You can see what there is perfect. You can see what I'm doing, by the way. For those of you that want to be neurosurgeons and do the Deuk laser disc repair, I'm taking the dilator and I'm adjusting it so that it goes where I want it to go at the back of the disc. So I'm pushing it up, pushing it sideways. And that's part of the surgery. Take a look at the hole. The whole surgery is being done through this 4mm incision. That's just enough room to get this tube in, and the whole surgery is done through this beautiful endoscopic tubular retractor. This is not a percutaneous surgery. Percutaneous means it's done with a needle. You put the needle in, and you're done. That's it. The whole surgery is through a needle. This is not a needle-based surgery. This is a true endoscopic surgery. And it is the future of disc herniation, disc bulge, neck pain, back pain, thoracic pain, radiculopathy, spinal stenosis, myelopathy surgery. As long as it comes from a disc issue, which 99% of the time it does. So this will literally take over the world someday and get rid of fusions and get rid of artificial discs. The problem is artificial discs and fusions make people too much money. And I'm not talking about you, the patient. They make the surgeon too much money. They make the implant company too much money. They make the hospital too much money. So none of those entities are really interested in moving into endoscopic surgery because there's no metal to put in. So there's no money to be made. You know, metal in the spine is a big, big, big business. And when you start messing with those big business people, they're like the mafia. They come after you. Shot? They want their money, you know? And they literally are like the mafia. And I'm saying that because I've already brought this surgery to them years ago, back in 2010. That was 11 years ago. And what have they done? Nothing. You know why? Because we don't put metal. They want you folks, they're using you all as guinea pigs to make money. And that's the sad thing about it. You guys are like, you know, patients getting fusions and artificial discs are like pigs or chickens, you know. You keep making them money and they're using you, slaughtering you. So that's why we broadcast, so people can become aware of the truth. You are in the matrix if you're getting spinal fusion and artificial disc.
Doctor, do you have time for a question?
You just consider yourself the human battery that the matrix envisions. Yes?
Okay, we have a question from a viewer in New York who's looking for an experienced surgeon. He wants to know how many herniation surgeries can be repaired in one visit.
How many herniations can be repaired in one visit?
Yes.
It depends on who you visit. Okay? So somebody is saying, hey doctor, how many herniations can a surgeon fix in one surgery? And the answer is, you can fix them all most of the time. However, most spine surgeons will do one at a time. They'll only do the worst one. And the reason for that is every time you come back, they make money. So you're like an annuity. As a patient, you're like an annuity for most spine surgeons. Not at Deuk Spine Institute. We'll fix them all in one surgery. Okay? So it just depends on, I'm trying to get this in the right position. I'm almost done. I think I'm happy with that right there. Yeah. All right. Here's the deal, folks. It's real simple. If you have 3 herniated discs and your surgeon fixes one, you're going to be coming back for another surgery because that one disc is going to give you some improvement and you're going to be like, oh my God, that feels so good. And then the pain is going to be back again from the other 2. And then you're coming back again 6 months or a year later, the surgeon will do another surgery. The surgeon loves it because guess what? We get paid a lot less if we do all 3 discs together than if we spread them out into 3 separate surgeries. You'll make about 3 times as much with 3 surgeries. So a lot of spine surgeons, not here at Deuk Spine Institute, but other places, they'll be happy to do 1 disc at a time and keep you coming back like a junkie, you know, hooked on the pain relief. So you can all learn the truth about what's really going on out there. Because I see patients as victims. They're victims of so many injustices in healthcare. And that bothers me. I didn't go into medicine to victimize my patients. I went into medicine to fix them once and for all with 1 surgery, 1 treatment. Just to give you an idea, the reoperation rate for an average spine surgeon is 25%. That means that 25% of the time of doing surgery, their patient will come back for another surgery. Okay? Do you see how you didn't get this on the other side here? Like these? Okay, you got to pay attention. So 25% of patients end up coming back for more surgeries, okay? Not here at Deuk Spine. For me, it's 1%. I've gone back, done my chart reviews, looked at all my patients I did surgery. 1% will come back, 1 in 100, and need another surgery. But that's not true for other surgeons, okay? So what you're up against, folks, is finding a surgeon who's ethical and who's capable of doing multi-level surgery if you need it, okay? So could you come to Deuk Spine and we fix all your discs? Absolutely, no problem. Could we do it all in 1 surgery? Probably not. It just depends on how many herniations you've got. We can do up to 4 areas, 4 like spots of herniation that are symptomatic per surgery. I mean, I've done 5, so I'm okay with 5. Depends on the patient though, like, you know, how healthy they are and their comorbidities, etc. Because, you know, the more you do, the longer the patient's under anesthesia. So if you're a quick surgeon and you do your work fast and safe, well, you could do more. So to answer your question, I would need to know how many disc herniations need surgery, where they're disc we did. This blue solid tell being inside the disc and seeing this. So not only does the endoscope allow me to fix the disc without fusing and everything, but it also allows me to figure out how old the disc injury is. And like I said, it's episodic. It's usually multiple stages. It happens in more than one stage. I'm very happy to see this because this kind of stuff responds really well to surgery like this. You have another question?
No questions, but we have a couple patients saying great information and thank you.
Yeah, that's why we're here. We're here to inform people.
We have a viewer from New York who said they will be contacting our facility.
Oh, good. Yeah, do yourself a favor. If you need surgery, come at least contact me and get my opinion. And I can answer questions. Like I said, we offer a free initial Zoom meeting. And first one's on me. I pay for it. Basically, I'm happy to answer questions for you. And obviously, we can't do surgery for free. We can do surgery for free under one circumstance. Anybody know what that is? Huh? Nope. If you can get Elon Musk or Jeff Bezos or Mark Zuckerberg to make a donation to the Deuk Spine Institute, which they should do, by the way, because they're multi-billionaires, all they need to do is put some money here and we can start treating everybody and not charge anyone any money. And that's my dream, to do that, to be honest with you. I don't want to have to ask people for money. I hate being like, what's it called? Wikipedia. Right? I'm not asking for money to teach. That'll always be free. But to do the surgeries themselves, they're not cheap surgeries. Oh, that's a huge herniation. They're not free surgeries. We do bill insurances, and most of the time they pay, but insurance companies have gotten so evil, they won't even pay for surgery like many surgeries that people need. Let's look at this herniation I just pulled out. Blue, you need a blue towel?
Yep, we can see it.
Okay. Well, we're going to turn the light on so you guys can see it even better. Now, that's not a huge one, but in the cervical spine, that's a pretty good size. Y'all see that?
Yes.
Let me show you right there. You see it better there?
Yeah.
Better there?
That back on the blue towel looks the best.
On the blue towel, that guy right there.
Perfect.
That's one piece of herniation, and that's a relatively new one. I would say it's months old. Could be 3 months, could be 6 months, but it's definitely not years like the other disc. So we're getting all these herniations out at this top disc. This is definitely the more symptomatic of the two, in my opinion. See that pink stuff right there? That's granulation tissue. Oh, there's a big herniation here. This patient must have really done something traumatic. This is a big, big blowout.
We have another question, Dr. Deuk.
Sure.
On Facebook, we have a viewer who said that they were watching, probably reading your blog, and she read that calcified discs do not cause pain. She wants to know, why is that?
That's a great question. The reason is simple. Calcified discs themselves have no inflammation. They're calcified. It's inflammation that causes pain. So it's only through inflammation in the annular tear that you can get pain. And a calcification doesn't have pain fibers. It doesn't get inflamed. It doesn't cause pain. The only thing a calcified disc can do that would require treatment is squash your spinal cord or your nerve. But usually it would be a spinal cord that's getting squashed. And then you need to do surgery. Okay, but calcified discs don't cause pain, they cause paralysis. Paralysis is painless weakness in your legs. You can't walk. You can't get out of bed. You can't control your legs. They're like you're falling everywhere. You can't even control your bladder. Okay? So, yeah, that's why. Calcified discs do not cause pain. They cause neurological dysfunction at worst. There's a piece of herniation right there I'm going to get in a minute, but I got all this stuff holding me back. This is a huge herniation. So, oh yeah, there's a piece right there. So basically, the C5-6 disc was very degenerated and long gone. The C4-5 disc, the one you're seeing now, look what a difference, huh? Look at all these pieces of herniation coming out. These are all chunks of nucleus pulposus that were basically fragments of disc herniation. We're going to send all this off to our pathologist, who's going to verify my findings with a microscope. And basically, yeah, this poor patient had a massive blowout here recently. No problem. We're about 10 minutes away from being done, doctor. So I don't anticipate being operating more than about 10 to 15 minutes. So if you want to start planning for that. Yep. So this herniation I'm dealing with right here is actually more central located, but you can see it's bad. And look at all the scar tissue right here. This is starting to set in. I don't think this herniation is all new. I think there's like an older tear, and then he probably blew out some more nucleus into the tear because it never healed. That's the problem when you get a tear and you get your herniation or bulge. The bulge is no different than a herniation. It is a herniation. It's just a smaller one. And when you don't fix it, like with the Deuk laser disc repair, it's the only way to fix a tear, by the way. There's no other surgery in the world that's been published to repair annular tears. I'm sorry, not repair, but debride annular tears. I didn't mean to say repair. Debride. Debridement means clean out all this grungy stuff that's keeping the annulus from healing. That's what a debridement is, and that's what we do here with the surgery. A debridement.
We have another question from Facebook.
Yep.
What is the median age of the patients that get this procedure?
What's the median age of patients that get this procedure? That's a great question. I don't know. I haven't looked at that in a long time. We published, if you go back to my publications, I think we mention it. So you'd have to go to PubMed. So type in PubMed under your Google or Safari, whatever. Type PubMed, P-U-B-M-E-D. And then once you get to PubMed, type in Deuk laser disc repair, spelled D-E-U-K, laser disc repair. And look at those papers that I've published. Those are back in 2012 and 13. And it should report under the materials and methods section the age of the patient, I believe. There may even be a distribution based on sex, male versus female. But in essence, the average age should be there, I believe. Okay, I haven't looked at my publication in a long time, but now, if you're interested, so am I, in doing research and publishing more. I'm actually looking for a research associate, someone who can help me write papers, because we have so much to publish, and I just don't have the time to do it all myself.
Dr. Deuk, we have another question from YouTube.
Yeah.
Why do so many doctors disregard bulges even though they're causing pain?
because they don't know so the question is, I always like to repeat the question in case everybody didn't hear it. Why do so many doctors disregard disc bulges in the spine even though they're causing pain? The answer is because they don't know they're causing pain. They don't know. It's a new discovery, and they just don't know it. That's what I like to believe. I mean, is it possible they're ignoring them? Yes, but I don't think that's the case. It's that they're taught, the dogma that we're taught as we're becoming doctors is you have to have a big herniation. It has to be crushing the nerve, like literally demolishing the nerve. Sorry, I'm just focused on what I'm doing here. So the herniation has to be massive and it has to be crushing. But that's not the case. The truth is the pain doesn't come from crushing. It comes from irritation. You know? And I don't know why people don't understand that. It's so simple and obvious. I mean, there's all kinds of arthritis in the human body, right? If you get arthritis in your knee, your ankle, your wrist, whatever, it hurts like hell in the joint. And that arthritis is inflammation. It's causing pain. As a matter of fact, there's a condition called discitis. Look it up, discitis. It's a rare condition where the disc becomes inflamed, the whole disc. Now, most of the time it's due to a bacteria, right? Infection. But there are a lot of times they don't know what causes it. The point is we know the disc can be painful. But for some reason, doctors think that pain is proportional to the size of the disc abnormality, and that small disc problems don't cause pain. Honestly, that's what I was taught too, but I found out that that was not true because I started doing endoscopic surgery on some small disc bulges. And the reason I did it was because I was doing endoscopic surgery on bigger disc herniations at the time, and the results were amazing, and I had no complications at all. And so I started to say, okay, well, we did an epidural, they got better. We did facets, and that didn't work, the rhizotomy. So maybe it's the bulge. So I would go in and tell the patient, all right, I'll try it, see if it works. And lo and behold, it worked. It took their pain away. So then I realized this is not a compression problem. Everything okay? Yeah. This is an inflammation problem. This is not a size of the disc. It's the actual inflammation from the tear. It has nothing to do with the herniation size. It has to do with the annular tear. It's the inflammation in the annular tear that's the problem. It's not the herniation that's the problem. Okay? Unless you have weakness in your arm, which a lot of people don't have. They just have pain. So that's why people are blown off by doctors for herniated discs that are small. Because number one, doctors don't realize that those herniated discs are the cause of their pain. But I discovered that here, and that's why we treat it. Everything okay, guys? All right, we're pretty much just about done here. I need 2 more minutes and we'll be done.
Looking back at your publication, the median age is 66 years old.
Of my patients? Are
yes,
you sure?
That's what it said on the publication.
Okay, I didn't realize it was so old. I'm surprised, but okay, thanks. The median age of the patients that I treated was 66? Wow, that's Medicare age.
That's what it says.
That's incredible. All right, just about done. Let me just check this foramen one more time. We've taken a lot of herniated disc out of this level. I just want to make sure I get it all. I think there's still a little bit left. Can I get some fresh coffee, please? Can you tell Deb? Deb is wonderful.
Yeah, I'm telling you now.
Coffee. I know none of you know this, but I will digress on something called professionalism. And professionalism is something that we don't see a lot of these days, unfortunately. It's just not how people are brought up anymore. But professionalism means when you have a job to do, you do it no matter how bad things are in your personal life. And you do it right, you do it to the best of your ability, you stay focused, and you do the best work you can. And, I'll use an example myself. Many people probably think my life is perfect, but it's far from it. My son was in a car accident last night. He's not injured, he's not in the hospital, but his car was totaled. And I came to work today and I did my job and I stayed focused on my task, even though my personal life I have issues that I have that are significant, okay? Why am I talking about it? Because I think there's too many people that are unprofessional, and I've had to deal with them here at Deuk Spine, employees that put their personal needs ahead of their professional work. And I'm mentioning it because I think it's wrong. And besides, I'm here to talk to you about how can we make things better in life. Well, I don't talk about politics, but I do talk about character of people and work ethic because that's important in my organization and the success of my organization and helping patients. I have a lot of professionals here, and I want to applaud my team because they are professionals. I have dealt with unprofessional people in the past. My team never gives me excuses. They always show up. They stay late when we're late. Nobody complains, and I'm just so proud of them for being true professionals. And so they motivate me to be a professional, to show up to work even though I've got issues that I have to deal with myself. All right, I think we're close to being done. There's still something here. This is, by the way, in case you missed it, this disc compared to the last one is 100 times worse. The last one we just did had some herniation and mostly bone spurs and scar tissue, but this one is horrible. Massive amounts of damage to this disc. I think this patient probably injured this disc recently and again, and there's so many fragments of herniation that are all about the same age. They're all looking to me like they happened around the same time. And the way I can tell that, once again, is by studying the fragments with the endoscope and how they respond to the laser and how they feel and how they look. Because what happens is over time a herniated fragment gets worked on just like a stone in the river gets worked on, right? And if you throw a stone in a river today and you look at it next week, it's going to look the same. But if you throw a stone in a river and you look at it in a few years, you're going to see that the river has smoothed the surfaces of the stone. And these fragments of disc are the same. The fresh ones are more chunky, and the old ones are more smooth and scarred up. All right, I'm just about done here. I don't see any more herniation down there. It's looking good. I may zap this stuff. I think I'm dealing with right here the posterior ligament, but I want to make absolutely sure. So I can see the fibers. That's looking like posterior ligament and possibly dura on front of the spinal cord. So I want to stay away from that. I don't want to go any further. I'm happy. This looks like some ligament here. I can peel. Just want to make sure I'm not leaving any pieces of disc herniation back here against the nerve or spinal cord. So I can use the laser to just peel layer by layer. It almost looks like there's still something there, and I don't want to leave anything. I think that's it. That's just ligament. We're done. All right, well, you can see the view you get at the back of the disc. It's like nothing else in the world. It's amazing. I'm going to call our blood loss 5 mil. We're pretty much done, folks. If you have questions, type them up. Our next surgery today will be a lumbar Deuk laser disc repair. Not as exciting as cervical, but our patient traveled from Canada, and she has an L5-S1 disc herniation, and she has a horrible pain in her leg and her back, and she wants it fixed. So she flew from Canada here, and she's having a Deuk laser disc repair done at L5-S1. Okay. That's going to be next. In the meantime, we're going to get this done. Now, what's funny is I've known this patient for years. Never treated him, but I've worked with him professionally. And when it came time for him to have a surgery done, he didn't want another fusion. So here we are doing endoscopic surgery. I hope the blood doesn't gross all of you out, but the surgery's gone very well. I'm very pleased. I feel like we got everything done we needed to, and I think he's going to be very happy with the results. Now, that said, I'd like for you all to take a look at the incision that we made. It's literally 4 millimeters. 4 millimeters is about 1/4 of an inch. I always apply pressure because sometimes there's a little bit of venous bleeding and you just want it to clot off and not become an issue. Now, because we haven't created a potential space by dissecting tissues apart, there's nowhere for a blood clot to form. So these patients don't get blood clots in their neck after surgery. I've never had that happen. Now, that said, I take precautions. Everybody that has this surgery, they're going to have all their anti-inflammatories, non-steroidal anti-inflammatories stopped a week before surgery. If they're on blood thinners or antiplatelet treatments, they're going to have that stopped a week before surgery. So if they're on ginkgo biloba, fish oil, turmeric, those type of herbals, they actually thin your blood and make you bleed. They prevent clotting, platelet function. We stop those a week before. So anything that would affect bleeding, we stop a week before surgery. Okay? And we don't have bleeding issues. We don't have blood clot issues. We've also never had a recurrent laryngeal nerve injury, and we've never had swallowing problems because the incision is so small. Now, if you have open surgery like an artificial disc replacement or a fusion like an ACDF, the patients always have trouble swallowing for weeks. Could be permanent. They could have a voice box, like a recurrent laryngeal nerve injury. Their voice box doesn't work. I was reading someone's post on Facebook the other day. They had ACDF and now they're hoarse. It's permanent. So that's one of the nice things about these minimally invasive endoscopic surgeries. We've had no complications like that to date. Okay? All right, let me show you this incision. There it is. So the whole surgery was done through a 4 millimeter incision. And Luis is going to close that up with the Band-Aid and maybe a steri strip. We're done. If you have questions, type them up. Make sure you visit the App Store and download the Deuk Spine Institute app for spine. It's free. And it's very informative. Also, we'll be starting our next surgery probably at 11:30 or closer to 12. Probably 45 minutes. What do you guys think? I have a very special patient sitting here next to me who's traveled all the way from Tennessee.
Yes, sir.
With his family for one purpose, and that is to get his neck fixed.
In the wild, I've trained animals for 25 years, not jumping through fiery hoops, but just mostly behavior, come, just a few words. We had 52 big cats, tigers, lions, leopards, cougars, lynx. This is me about 6 years ago in the tiger cage. And this guy here, he's we raised him from a baby.
That's special.
I'll tell you what, the special part is being here.
And how long have you been dealing with this problem with your neck?
It's come on in the last 8 weeks strong, but after I start thinking about it, you know, even 6 months ago, I was seeing things happen that I couldn't understand why. And I just want to get back to somewhat where I was at and get the feeling back in my hands, my stability, a little strength where I can get this boy up.
Well, what's going on, as we've talked about, is you've got these herniated discs, bone spurs in your neck that are pinching down on your spinal cord and nerves. And I'm going to go in there tomorrow with a laser, and we're going to open all those spaces up, get the pressure off the spinal cord and the nerves, so you can start getting some feeling back and strength back in those arms.
That sounds great. That's why I'm here. Then I've researched, and I kept coming back to you all and seeing the testimonies and seeing, watching hour after hour after hour of the surgery. And that, you know, that says a lot if you can do it live on Facebook. It's just a pleasure to be here. I feel safe. I feel like when we arrived last night, we drove up in front of the place, and I told my crew and my wife and my driver, I said, we have arrived. We have arrived. Thank you so much.
We'll see you tomorrow morning, all right?
I appreciate it so much.
So we did surgery yesterday with the laser. Everything went really well. You can actually see the 4mm incision right there, 3 discs. He didn't want fusion, and so he found Deuk Spine Institute and he came here.
After the surgery, when I talked to her, I was still a little bit drowsy. And 4 hours later, we were sitting over at a restaurant, seafood restaurant, eating seafood, and I could clap my hands with the baby because he claps when he does something good. And I could clap with him without missing my hands.
Hello everyone, Dr. Deuk will be ready in just a moment. He is leaving the operating room and heading over to our recording center. He will answer all the questions that you have prepared for him, but make sure to download the Deuk Spine Institute app, as you can find more information about your spine conditions. And also remember to go on mri.deukspine.com to submit your free MRI report. Dr. Deuk will personally see them and evaluate your condition, but Dr. Deuk will be on his way currently. Make sure to type up your questions momentarily.
I have a very special patient sitting here next to me who's traveled all the way from Tennessee.
Yes, sir.
With his family for one purpose, and that is to get his neck fixed.
In the wild, I've trained animals for 25 years, not jumping through fiery hoops, but just mostly behavior, you know, come is, you know, just a few words. We had 52 big cats, tigers, lions, leopards, cougars, lynx. This is me about 6 years ago in the tiger cage. And this guy here, we raised him from a baby.
That's special.
I'll tell you what, the special part is being here.
And how long have you been dealing with this problem with your neck?
It's come on in the last 8 weeks strong, but after I start thinking about it, you know, even 6 months ago, I was seeing things happen that I couldn't understand why. And I just want to get back to somewhat where I was at and getting the feeling back in my hands, my stability, a little strength where I can get this boy up.
Well, what's going on, as we've talked about, is you've got these herniated discs, bone spurs in your neck that are pinching down on your spinal cord and nerves. And I'm going to go in there tomorrow with a laser, and we're going to open all those spaces up, get the pressure off the spinal cord and the nerves, so you can start getting some feeling back and strength back in those arms.
That sounds great. That's why I'm here. Then I've researched, and I kept coming back to you all and seeing the testimonies and seeing, watching hour after hour after hour of the surgery. And that, you know, that says a lot if you can do it live on Facebook. It's just a pleasure to be here. I feel safe. I feel like when we arrived last night, we drove up in front of the place, and I told my crew and my wife and my driver, I said, we have arrived. We have arrived. Thank you so much.
We'll see you tomorrow morning, all right?
I appreciate it so much.
So we did surgery yesterday with the laser. Everything went really well. You can actually see the 4mm incision right there, 3 discs. He didn't want fusion, and so he found Deuk Spine Institute and he came.